Colleagues, my name's George Rubin and I'll be your MC for the conference. I hope you'll bear with me as we go for the conference. I'd like to welcome you all to this fantastic event. This is the first, or the inaugural, myPHN conference. I'd have to say North Queensland PHN has the jump on all the other PHNs in the country. This is the first event of its type in the country for the first time. So the theme of the conference is Connecting General Practice for Better Health, and I'm sure you'll agree that we're going to have a very exciting event, so I hope you all enjoy it. So colleagues, just a few things I'd like to show my respect and acknowledge the Yirrkala people and the Gimoy, please excuse me if I don't get this right, Gimoy, Walubara, Yidinji people who are the traditional custodians of this land on which the event takes place. And I'd also like to pay my respects to their elders, both past and present, and to other Indigenous people, other Indigenous Australians who are present. Some housekeeping points. Toilets are located through the doors and then just on the left-hand side. Catering will be served in the trade exhibition area. And in the case of an unlikely emergency, please remain calm and follow the instructions of the Pullman staff who are very competent. I'd like to thank the major sponsors of the conference. We have bronze sponsors, which is the Office of Industrial Relations, and Indivior. Media partners are the AMA Queensland, the Australian Medical Association Queensland, and of course all the other trade exhibitors who are in the trade area. So thanks to all our sponsors of the conference. Now colleagues, if you'll permit me just to make a few introductory remarks before we kick off, I'd like to just, first of all, I'm a public health physician. My position is Associate Director, Medical Director in the Southeastern Sydney Local Health District. We have 3 major teaching hospitals and about half a dozen other healthcare facilities in our district. We serve 900,000 people and we have a budget of about $1.6 billion. I'm also a clinician. I practice in addiction medicine, so I do touch patients. So colleagues, I'd like to suggest to you that there are 7 major challenges in healthcare that we all face at the moment. First of all is the scarce healthcare dollar, so it's incumbent upon all of us to do the best that we can to make sure that we're getting the maximum health benefit for individuals and communities from the available health dollar. That's the first point. The second point is we need to be trying to make sure that all community enterprises promote and or protect health to the best of our ability. The third challenge is to identify the health gaps in our communities. The health gaps, the inequities, the health gaps in health status, the health gaps in services available for all of our communities and the subgroups of our communities. The fourth major challenge is to ensure that all our efforts are underpinned by good health data. And by this I really mean that health records are available wherever they're needed at the point of care. So where health professionals are providing care, ideally we want all the available health information to be available there at the point of care. The fifth is that individuals and communities are involved in their health care and their protection, the protection of their health. That's a very important one. And sixthly is that the challenge for all of us is to ensure that we have integration of our services, connecting general practitioners, allied healthcare workers, other health professionals, all health professionals, hospitals, health organisations, carers, and patients, if I may, patients, clients, consumers, whatever your terminology is, that's always a difficult one. And really this issue of integration is a major theme in this conference. And the final challenge that I want to put to you is that we need to all be concerned about continuous quality improvement. Now you say to me, what do you mean by quality, George? And I'll tell you very simply. One, that services are person-centred. That means that the person, the patient, the consumer is at the centre of the consideration of the service. Second, that those services are technically proficient and safe. Thirdly, that they're based on the best available scientific, medical evidence, if you will, but let's call it scientific evidence. Big challenge there. Fourth, that they're prevention focused, that we're trying to prevent illness, disability, and suffering, rather than treating it after the fact. And finally, that they're well managed for efficiency, equity, and accessibility. So the sessions over the next 2 days will touch on all of these elements, and I hope that we can all learn together, and I hope that you have a very stimulating time at the conference. Now, if I may, I'd now like to introduce Mr. Trent Twomey. Where's Trent? Trent is the chairman of the Northern Queensland Primary Health Network, and along with being chairman of the Public Health Network, he's also the chairman of Advance Cairns, the peak economic development and advocacy organisation for tropical Queensland, a national councillor of the Pharmacy Guild of Australia, a member of the Council of James Cook University. He's a fellow of the Australian Institute of Company Directors, a council member of the Queensland Futures Institute, a trustee for the Committee for Economic Development for Australia. It goes on. A very impressive individual. And so Trent and his wife are both pharmacists. They live together. They have 2 children. I was going to say they live together in Cairns. And they have a group of 7 pharmacies that they run. And as I said, they have 2 children live in Cairns. So Trent, over to you. Apologies for that.
You did well. Yeah, you can sit there. Okay, no worries. Oh, well, at least if he's going to have his trainer wheels on, he could do it with me, hey, so that was all right. Thank you for that, Professor, Minister, and my CEO of the Primary Healthcare Network, Robin Moore on the end there. Thank you very much, Henrietta. It's always an absolute pleasure to see one of your welcome to countries. I never bore of them, and I really appreciate your leadership that you provide in this area, so thank you very much. And those dancers, what a wonderful job they did as well, so thank you to the dance group. So as I said, the Honourable Cameron Dick MP, Minister for Health and Ambulance Services, Dr. Daniel Halliday, National Councillor of the Australian College of Rural and Remote Medicine, is with us today as well. Mr. George Tambassis, National President of the Pharmacy Guild of Australia, and State President Mr. Tim Logan. Professor Richard Murray, Dean of the College of Medicine and Dentistry at James Cook University, and also board members and chief executives of the Hospital and Healthcare Services of Cairns, Townsville, Mackay, and Torres, and Cape Hospital and Health Services. Fellow delegates, welcome. Firstly, I would like to pay my respects to the traditional owners of the land on which we stand, the Gimwe, Wallaburra, Yidinji people and the Irriganji nations, and pay my respects to their elders past and present as well. I would like to welcome you all to Cairns in magnificent tropical North Queensland. This is a really chilly winter day for us, so I just like to rub it in, quite frankly. My wife, who occasionally likes to live with me, is from Tasmania, so she really enjoys it. Thanks for that. As the Chair said, this is the inaugural conference for the Primary Healthcare Network of North Queensland, but it is also a first for the country as well. This is the only PHN conference in Australia. So I'd just like to take that opportunity to just stop and thank the many hundreds of man-hours that Karen, where is Karen? Where is she? Down the back there, that her and her team from Mackay put this together. So thank you very much, ladies. Well done. It's a very special week, not just because it's school holidays, but also because it's NAIDOC week. And NAIDOC week started last Sunday, and it also continues until tomorrow as well. It's been a special week for not just the PHN, but for Aboriginal and Torres Strait Islander people. And at the Primary Healthcare Network, we're determined to play a key role in closing the gap. I paid my respects to the traditional owners on the land on which we stand, but the other unique point about the North Queensland Primary Healthcare Network is we are the only PHN to have both of Australia's traditional cultures, the oldest continuing surviving cultures on the planet, and of course I speak of the Torres Strait Islands. So if there are any Torres Strait Islander people in the room, I'd like to acknowledge you as well. It does not have to be the case that our Indigenous Australians will live 17 years less than the rest of the population, or that Aboriginal and Torres Strait Islander babies will die at almost 3 times the rate of the rest of the children in our community. We need to reduce inequalities that currently exist in Aboriginal and Torres Strait Islander people in regards to health, and we are determined to do just that. This is the first of what will be an annual conference. So I haven't told Karen yet, but we're doing this every year. So you heard it first here, so I'm glad you're way down the back so you don't clobber me one. We have people not just from our footprint, which extends from Sarina in the south all the way to the Papua New Guinean border, but we have people from South Australia, we have people from New South Wales, we have people, I think, from every state except, is there a Northern Territory in here? Oh, there's a couple, fantastic. Hello, fellow Northern Australians. I just want to say, we chose the title myPHN for a reason. This is your PHN. It belongs to you. It doesn't belong to me. Doesn't belong to any of the levels of government. It belongs to the primary healthcare people of North Queensland. Now, the Australian Institute of Health and Welfare defines the primary healthcare workforce as community-based GPs, dentists, pharmacists, nurses, and allied health professionals. So that pretty much covers all of you in the room. So to the GPs, dentists, pharmacists, nurses, and allied health professionals of North Queensland, this is your conference, and this is your organisation, and we're here to support you. Now, patients move from GP surgeries to pharmacies to Aboriginal medical services and allied health practices with very limited visibility. Now, billions of dollars, Minister, billions of dollars, in fact, just over $2 billion a year is spent on the 700,000 people in the North Queensland primary healthcare footprint. Just over $2 billion by the state government through the hospital and healthcare services and commission contracts that they run, by the Commonwealth through the MBS and the PBS, and by patients through co-payments and out-of-pocket expenses. This lack of visibility makes it extremely difficult for patients to navigate the primary healthcare system, and it does not encourage empowerment. It makes it difficult for a GP to coordinate and connect with other primary healthcare providers, and makes it difficult for them to care for their patient, which is the reason we have the theme of this conference. Now, these are not new problems. Steps were taken to address this issue with the previous development of the divisions of general practice in the early 1990s and then to the Medicare locals roughly a decade ago. As I travel around the footprint and I visit you in your surgeries and in your practices, you all say the same thing. Trent, how is it going to be different this time? How will the PHN succeed where the divisions and the Medicare locals really struggled? Well, for a few reasons, and I'll tell you what those reasons are. Firstly, because of the advancement in technology, okay? We now have greater integration with the state healthcare system and your practice software. Whilst it's not perfect, and we have the rollout of the My Health Record system, and I'm sure most of you have very strong opinions about that, and there's a stand over there that you can go and ask the Commonwealth about. It is a vast improvement on what we had in the early 1990s. Secondly, there is a desire at both levels of government and on both sides of the political divide, motivated in some part by financial pressures, but by a realisation that more money is not necessarily the answer, and an acknowledgement that Brisbane and Canberra do not have the answers. Thirdly and finally is culture. And I'm talking about the culture of the primary healthcare network. A culture that starts with me and my board, goes down through the CEO to every single employee of the primary healthcare network. A culture that drives value for money for the taxpayer. A culture that refuses to build another bureaucracy. A culture that is here to provide practice support and to build your businesses, because we know that if your practices are healthier, then the community is healthier. Following a review by Australia's former Chief Medical Officer, Professor John Hovarth, the Australian government decided to take up the suggestion for new local healthcare networks, and the eventual name was the PHN. These PHNs have two overarching objectives. The first was to focus on efficiency and effectiveness of medical services, particularly for those at risk of poor health outcomes. The second was in coordination of care. Funding is focused on frontline services and on the people who provide those services, identifying health service gaps at a local level. PHNs have 6 priorities nationally: mental health, Aboriginal and Torres Strait Islander health, population health, health workforce, digital health, and aged care. Now, patients have the opportunity to have their say through community advisory councils, councils that are shared between the primary healthcare network and those 4 hospitals that I mentioned at the beginning. Now, this is also the only PHN in the country that has shared community advisory groups with the hospital and healthcare services. And I just want to thank the HHS board directors and senior executives for their cooperation in that. Now, people don't know what is a state and a Commonwealth responsibility when it comes to health. They just know about the health problems in their community. And it's up to us on behalf of the Commonwealth, and it's up to the state hospitals on behalf of the state to figure out who that responsibility is so we can cut through the mess. The second point, very importantly for those people in the room, are the GP-led clinical councils. Now, on those clinical councils, we have local GPs, local dentists, local pharmacists, local nurses, and local allied health professionals. And their job is to tell us how we can do business with their network better than what we're doing today. The structure of the PHN board gives a direct link between the community and you through those 2 structures that I just spoke about. Now, it's all about connecting health, and the PHN is determined to play a role to make this happen. Now, a lot of great work has already been done in trying to create better connectivity and coordination across healthcare providers, but we've still got a lot of work to do. For example, last month was our inaugural health needs analysis. Now, we refer to this as the continual health needs analysis, and I'm looking at the COO over there. This is not a stagnant document. We pull data from your hospitals, Minister. We pull data from your pharmacies, from your GP surgeries. We pull data from your Aboriginal medical services. But it is not a complete data set. If you have a source of data that you think would be able to give the primary healthcare network a greater and more clearer picture of what is happening in your communities, then put up your hand and go and see that man right there in the 3rd row. So the job of the clinical councils is to say, well, that data's all very well and good, but it doesn't quite reflect what my community is struggling with. Now, there is no such thing as Northern Queensland. We have 31 local government areas. We have 31 different communities. So through our full-time epidemiologists, we break down that data that we get into each of those local government areas so we can have a conversation with the 3rd, and quite often in a primary healthcare space, especially in the Cape and the Torres Strait Islands, a bigger player than the other 2 levels of government. We recognise and are committed to fulfilling the role in partnering with organisations and governments to improve the underlying social determinants of health, to enable long-term sustainable health investments across the region. Now, the health needs of North Ward, Yarrawonga, are pretty different to the health needs of Arakoon. Okay? So we have to have different approaches. We have to have community-led approaches, and we have to have place-based solutions. In summary, we cannot improve primary healthcare system and undertake the necessary reforms that are needed without you. The theme of this conference in this inaugural year is connecting with general practice. Now, I personally chose that title, right? And usually I get, because I'm the chairman, anything that goes wrong was my idea and anything that went right was a great team effort. But the reason I was pretty firm about that, and I get firm about a couple of things as a CEO will tell you, was because we recognised that the Medicare local structure, and they had the very best of intentions, lost the support of general practice. So the first thing we're doing is doing everything we can to win back that trust. This brings me to this weekend's conference and why we're all here today, and the theme for this inaugural conference, connecting with general practice. With the increasing calls for enhanced integration between primary healthcare and acute healthcare, general practice must be supported to improve the patient journey, ensuring consumers receive the right care at the right place at the right time. The myPHN 2016 conference has been designed for regional, rural and remote healthcare providers and their teams to connect with their colleagues, network and are having access to the highest quality educational opportunities. We've planned an exciting conference which includes access to conference workshops that focus on those key priority areas that I outlined at the beginning. We've localised it, we've focused on things like methamphetamine addiction, suicide prevention, and of course, practice sustainability. And I'll just touch on that point for a moment. Now, we have a few staff, Georgina and I, and we have a few pharmacists that work for us as well. But I can have the very, very best clinicians money can buy. But if I do not have great support staff and great technicians my model of delivery, the pharmacy as opposed to the pharmacist, does not work. And it's the same thing for general practice. So we will be having, as we have down in Mackay, but we'll be rolling it out across the rest of the footprint, dedicated business training for the practice support staff as well, because general practice is a business. We identify that, and we'll give you every clinical as well as business tool we can to help you succeed. The preliminary sessions will address an array of national and local health issues and social issues, and our inspiring keynote speakers and conference streams on innovation, connected care, and of course, Aboriginal and Torres Strait Islander health. I think this is a fantastic opportunity to see the diversity of healthcare providers, including, and I'll keep saying it, GPs, pharmacists, dentists, nurses, and allied health professionals. At the PHN, we're passionate about making health services more accessible and tailoring them to community needs, producing cost savings through reducing preventable hospital admissions, which is something that I know the Minister ran a workshop on up here only last year. We can't do this without you, as I said before, and to achieve these aims, we need focus. I really do see this conference as something that belongs to you. We do want your feedback. When the conference ends tomorrow at 3 o'clock, our team and I have a meeting for an hour to decide on how we can do it better next year. So please come up to me, come up to any of the NQPHN staff in those great NAIDOC shirts and provide us with the feedback. I'd now like to introduce the Honourable Cameron Dick MP, Queensland's Minister for Health and Ambulance Services. Minister, we look forward to working with you and your department to reduce duplication and waste, to improve transparency and coordination. We believe with the right systems, with the right culture, and with the right amount of trust, we can work together to better utilise the private and not-for-profit, non-hospital primary healthcare system to be able to reduce the pressure and cost on your public system. These reduced pressures will create savings that can be reinvested into the higher-level tertiary clinical plans of our local hospitals to ultimately deliver better health for North Queensland. Ladies and gentlemen, please join with me in welcoming our Minister for Health.
Thanks very much. Well, thanks, Trent, for that welcome. And in NAIDOC week, can I begin by acknowledging the traditional owners of the land where we gather today, and thank everyone for their, particularly our Indigenous dance group, for their terrific performance today that captures not only the songline of Aboriginal and Torres Strait Islander history, but interprets it in a modern way that we saw today, capturing the 3,000 generations of continuing cultural practices in this great continent we call Australia, and reinterpreting that for all of us here today. So it was a wonderful presentation, and I thank you again for that. Can I acknowledge all of the other distinguished guests here today? Can I thank Trent and the Northern Queensland PHN for pulling this conference together, a great initiative, and I want to acknowledge Trent for his leadership and the CEO, Robin. Robin Moore, can I also acknowledge you, Professor George Rubin, as the Chair? Can I acknowledge all of the leaders in healthcare here today, whether David Rosengren's here, the Chair of the Clinical Senate, leaders in Aboriginal and Torres Strait Islander healthcare, our leaders in hospital and health services. I know Carolyn Eagle, the Chair of the Cairns and Hinterland Hospital and Health Service, and Claire Douglas, the Acting CEO, are here. We've just been up on the tablelands with some very happy communities where we're delivering new health infrastructure, both in Atherton, a very significant redevelopment of the Atherton Hospital, and rebuilding the primary healthcare clinic in Dimboola. Wherever you come from, you are welcome. You're welcome in our state. I know a number of you have come from interstate. And what a glorious Queensland day we have today. Cairns has really turned on the weather. The beauty of me being as the Minister for Health, you can travel 4 hours north from Brisbane, you can fly for 4 hours north, and you are still in Queensland. If you're from Melbourne, you travel 4 hours south and you're basically in Antarctica. And if you've ever been to Victoria, there's probably not much difference when it comes to the climate. So we've probably lost the Victorian delegates there, Trent. But it is great. Wherever you've come from, you are welcome in Queensland, and we've turned on some fantastic weather for you. So welcome. Everyone knows, I think, in this room that this is a time of great change, great challenge, and great opportunity for the health system, particularly in Queensland. I'm very pleased to be in Cairns, one of our major regional cities in Queensland, a major regional city that plays a role, a unique role in the delivery of healthcare services, not just for urban communities here in Cairns, but also for the Cape, for Torres Strait, and responds to all of the challenges that service delivery involves. Again, can I thank the Northern Queensland Primary Health Network for hosting this conference and bringing together so many people who are passionate about the delivery of care in our state. Today, I'd like to talk about three things. Firstly, I want to address My Health, Queensland's Future, Advancing Health 2026, which is the Queensland Government's attempt to crystallise what we see as the future role of the health system in Queensland. Secondly, I want to make a few observations about the federal election and national health policy. And finally, I want to look at some concrete examples of collaborative leadership within the system, which I think provides a framework for confronting some of those challenges and opportunities that we must embrace. Our health system is very different to the health system that existed 10 years ago. Over the last decade, the system has had to deal with massive changes as demand has outstripped population growth. 10 years ago, Queensland's population was 4.1 million. It is now 4.7 million, a rise of 15%. In 2005-06, there were 1.3 million presentations in accident and emergency departments in Queensland. In 2014-15, so 9 years later, there were 1.8 million presentations, a rise of 40%. In 2005-06, there were 750,000 public hospital episodes of care. In 2014-15, there were 1.2 million, an increase of 60%. So while the population of Queensland has increased by 15% in just under a decade, two major health system indicators, accident and emergency presentations and medical services, particularly episodes of care, show an increase well and truly above population growth. That rate of change, I believe, will continue in that path over the next decade. In May this year, I was very pleased to release My Health Queensland's Future, Advancing Health 2026, which sets out our vision for the health of Queenslanders over the next decade. As well as a growing and ageing population, our health system faces other significant challenges, including high rates of obesity and increasing rates of chronic conditions, such as diabetes. Another challenge is that the health status of some individuals, as Trent has commented upon, varies markedly. For example, the life expectancy of Aboriginal and Torres Strait Islander people is around 10 years less than for the rest of the population. People living in rural, regional and remote locations, and those that are socially, economically disadvantaged, also have poorer health outcomes. If Queensland's health system is to continue to rank amongst the best in the world, it has to rise to these challenges and embrace new opportunities. Advancing Health 2026, which was developed in consultation with all participants in the delivery of healthcare in Queensland, that framework will guide our investment priorities over the next decade. Our overarching vision is that by 2026, Queenslanders will be among the healthiest people in the world. Advancing 2026 also provides a framework for other parts of our health system, not just the public health system, to use as a way. We want those parts of the system to use that framework to guide their decision making and to encourage coordination and collaboration, because no part of our state's health system, no part of our nation's health system exists in isolation. Our vision is supported by 5 overarching principles: sustainability, compassion, inclusion, excellence, and empowerment. And those principles will guide everything we do in the public health system. Out of those principles comes 4 directions: promoting well-being, delivering healthcare, connecting healthcare, and fostering innovation. Those 4 directions will guide our strategic agenda over the next decade, and they will provide order and direction in everything that we do in the public health system. We also want to set out headline measures of success. So we have our principles and our directions, but we want to achieve substantial improvements in a number of demonstrated areas over that 10-year period. So some of those headline measures of success, including, hopefully not too much excess, some of those headline measures of success include reducing childhood obesity by 10%, reducing the rate of suicide deaths in Queensland by 50%, increasing the life expectancy for Indigenous males by almost 5 years and by females for around the same figure, increasing the levels of physical activity for health benefit by 20%, and increasing the availability of electronic health data to consumers, which I think will radically change the health system over the next 10 years. So while those measures are ambitious, we all want to agree on, I believe, common goals. Making Queenslanders amongst the healthiest people in the world is an aspirational vision, but it can only be achieved by inspiring individuals, the health sector, and all parts of the community to work collaboratively to achieve the common goals set out on the vision. And I'd encourage everyone in this room to get hold of a copy. It's available obviously online through the Department of Health, Queensland Health website, as a guide to your decision making wherever you work in the health system. One of the key decisions weighing on all of our minds at the moment, particularly those of us who lead in health, is the outcome of the federal election and the impact that that will have on the policies to be followed and implemented by an incoming federal government, no matter which party forms that government. There's been a lot said about the role that healthcare has played in the federal election, particularly Labor's campaign. As Malcolm Turnbull said, Labor's campaign resonated because it fell on fertile ground. Soil tilled and made ready by the federal coalition's approach to the funding of public health services, many decisions that were made unilaterally without collaboration, particularly with states and territories. And one of the reasons for that is because of the National Health Reform Agreement that everyone had signed up to in our nation, across political parties and across levels of government, that was set aside on the election of the Abbott government. From the perspective of the community sees, I believe, and appreciates the value of Australia's public health system. They want that public health system to deliver results, whether it's access to a bulk bill GP appointment or improved elective surgery outcomes in public hospitals in Queensland. I was delighted yesterday to announce some significant achievements we've been able to deliver in Queensland over the last 18 months, thanks to the hard-working staff in our Queensland hospital and health services. In 2002, we first started recording the number of ready-for-surgery patients in Queensland across categories. Category 1, surgery within 30 days. Category 2, surgery within 90 days. Category 3, surgery within 365 days. And this month, and one of the key performance measures for our health system is how many people have to wait longer than clinically recommended. How many people have to wait longer than the doctor recommends for them to get their surgery? And so for the first time since 2002, we've delivered the lowest number of long waits for elective surgery in Queensland, 161. That's half of what it was when we came to government a year ago when it was 324. Similarly, with outpatient specialist appointments, 100,000 people in Queensland waiting longer than clinically recommended to see a specialist in a public hospital in Queensland, down to just under 69,000. And that's because of an investment in people, the people who make a difference in the delivery of healthcare. And Trent has commented on that earlier. It's the people who make a difference who deliver healthcare in Queensland. So I believe we need an urgent recommitment to the principles and the framework established under the National Health Reform Agreement. I believe the Australian Government needs to fund 50% of efficient growth in our public hospital services without arbitrary caps that limit our ability to meet the required growth in services. We need the Commonwealth to deliver new national partnership agreements to help drive reform and efficiency in the system, to help keep people healthy, and to provide assistance and support, particularly in areas of preventative health, mental health and dental care. I believe the Medicare rebate freeze needs to be lifted so bulk billing can continue, allowing Queenslanders to visit their local GP instead of clogging our emergency departments. And I'll touch on some of those figures and the impact on emergency departments in the growth in demand shortly. These are real challenges in healthcare, and I am happy to commit to being a constructive player in finding collaborative solutions. So I've given the federal government the benefit of my views. Perhaps I should look to myself as well and apply the same rule to myself and spend some time talking about what we've tried to achieve in the health system in Queensland and what I think we can do better. As I've said, we're all aware of the demanding challenges that the healthcare system faces. So I would like to spend some time talking about some of the demand solutions that we're working on and how collaborative leadership has been at the heart of our approach, which is one of the reasons I want to be here today. Everyone in healthcare is a leader, and we need collaborative leadership, all of us working together to deliver outcomes. The demand challenge we face gives us an opportunity, I believe, to redesign how we deliver healthcare with the aim of driving care down the acuity chain to ensure that we constantly focus on the efficient use of community resources, because a healthcare system at its heart is a community resource. I think to do that, as all of you, I think, would agree, to do that we need better integration. We need better integration between primary and acute care. We need to improve the flow of information between hospitals, specialists and community and primary care providers. Improved communication, which will benefit GPs and community care of patients, is being targeted as part of our government's outpatient waiting strategy and our e-health strategies. These strategies include GP access to the viewer in Queensland Health. Now, you know the viewer is the information system in our public hospitals, but currently it's only available to people working in the public hospital system. And as many of you know, I've recently introduced legislation into the Parliament to ensure that general practitioners throughout Queensland can get access to the viewer. That will enable discharge summaries to be sent to myHealth records providers, and that will allow clinicians and others in the general practice space to get access statewide to that information. And I think that communication, that connection, that access to data and information will provide the foundation for connected care. We've also been willing to admit that we don't have all the answers, and we want to acknowledge and recognise the need for collaborative partnership to improve integration. In that respect, I've been absolutely thrilled by the response we have had to our Integrated Care Innovation Fund. Some of you might know that earlier this year I announced a pool of $35 million which will support projects across Queensland to generate new ideas for the better integration of care, to address fragmentation in services and to achieve greater efficiency and value from health delivery systems. So I was astonished to discover that we have received well over $120 million worth of project ideas from the sector. And to me, that's the sort of problem I would like to have. That shows you that we are tapping into something. That shows that we have connected with primary health care through our acute hospital system, through our public hospital system, that we are tapping into a need and are tapping into a general and a a very generous desire from primary health care to work closer. And I think this will be a great way to identify some of those projects that can build a platform and demonstrate effective outcomes in better integrating with primary care. Sadly, I've got to tell you, I can't fund all of the projects. I can't get it to $120 million, but the Treasurer's from the northern part of Queensland, so if anyone sees Curtis Pitt, make sure you say it's a great project. And if we need more money, we'll see what we can do. But I think the interest that this program has generated and the quality of the responses that we received that are so high demonstrates we're on the right track. And I hope to make announcements about successful projects in the very near future. Given the nature of your role and the work that you do across the system, I also wanted to touch briefly on the issue of growth in patient attendance at emergency departments, something I mentioned earlier. From June 2015 to the end of May 2016, so not quite a year, a little under a year, about 11 months, there was an 8.2% increase in the number of people attending EDs in Queensland compared to the same period on the previous year. That ended up being an extra 100,000 people coming through the doors of emergency departments around the state in 1 year. The biggest growth though, and this is the most interesting thing, the biggest growth in emergency department presentations has been in categories 3, 4 and 5. And so everyone here knows that's the low acuity patients coming into EDs. Last year, 43.2% of ED presentations in Queensland were for categories 4 and 5. It's very significant. If people need to go to a hospital, they will always be treated. But these figures show that more people are presenting to EDs when I genuinely believe they could have been treated elsewhere. I'm a strong supporter of the primary health system in Australia because if people are treated closer to their families, closer to their workplace, closer to their community, that is good for everyone, the patient, the health system and the Australian community. Along with promoting our message to keep EDs for emergencies, we're also providing assistance to patients looking for a new GP. Patients can now visit the Queensland Health website and find a local GP in their area, including services and opening hours and after hours opening hours as well. The Queensland Health website links to the National Health Services Directory, which allows quick and easy access to centrally maintained National Health Facility information. And I know the PHN in Brisbane, the North Brisbane PHN, has recently developed an online portal that comes up effectively like an app, as you know, like most websites do now, that colour coordinates and colour categorises options for individuals who need healthcare. So they'll link you through to 13 Health, they'll link you through to an after-hours doctor, they'll then suggest if it's a red colour, obviously a serious illness, you can go to an ED. And this is being led by clinicians, it's being led by PHNs like the far northern PHN. This is doctors at the coalface trying to communicate that message. Our 13 Health system in Queensland continues to be a 24/7 quality source of advice for patients concerned about their health or the health of someone they love or live with. The statewide work is important and something I strongly support, and I also want to recognise the need to tailor local solutions for local communities, which is exactly what the PHN in the far north here is trying to do. In that regard, I'm pleased to be able to report what we've been able to do collaboratively here in the far north of our state. As Trent touched on earlier, in September last year I convened a roundtable discussion to work through issues related to Queensland Ambulance Service access to emergency departments and patient flows. As a result of that roundtable, we announced 10 initiatives to be implemented. Of those, 9 have been fully implemented, including a low acuity response unit that the QAS has rolled out, the establishment of a dedicated patient management unit within Cairns Hospital, tighter local escalation processes that operate between the QAS and the emergency department, better use where appropriate of rural hospital bed capacity to provide better patient flow and more options for clinicians and patients, enhanced access to up to 6 additional transition care packages to assist the accommodation of long-stay patients, which is a really significant issue here in Cairns, disproportionate to other parts in our state, particularly for individuals seeking aged care placements. On the back of those changes and a focused effort from staff within the HHS, and again I want to thank Carolyn for her leadership, the QAS has managed to sustainably improve patient off-stretcher time, the post time we record in Queensland, the post performance in this part of Queensland. The target for all HHSs is to get patients off stretcher within 30 minutes and 90% of cases off stretcher within 30 minutes. And I'm delighted that we've improved from 80.8% in August last year to 89.3% in June. That's a great achievement, but we're about to hit the flu season, so that changes everything in our healthcare system, but we've tried to respond and develop for the first time a statewide winter bed strategy for our hospitals. We'd never developed a dedicated strategy before, but we're rolling that out now to get ready for flu. That level of performance, I'm pleased to say, here in Cairns has been consistent over a number of months, which I think is great news for the Cairns community and a reflection of what we can do through collaborative leadership, a great example. Collaborative leadership, local initiatives leading to better outcomes. So thanks very much for having me today. In conclusion, can I just say this conference, and again thank the Northern Queensland PHN for their leadership. Today's conference presents an important opportunity to define shared goals and unity of purpose is what we all need. And I thank you. I thank you for your participation. I invite you to participate fully and work innovatively so we can construct the health framework we all need for the next 10 years in Queensland. Thanks very much and enjoy the conference.